She did her surgical training at Brown University and then came to the U of T for her surgical oncology fellowship. And Dr. Law and I said to each other, we need to have this young lady join the U of T Sunnybrook staff. And Dr. Coburn is a hepatobiliary oncologist. She specializes in treatment of tumors of the liver and pancreas and bile duct cancers. She has also a very special interest in gastric cancer and obviously in neuroendocrine tumors. She is also, amongst many other things, a scientist in ISIS, which stands for the Institute of Clinical Evaluative Sciences, and also on staff at the HPME Department, Health Policy Management Evaluation at U of T, and many other things. So, Dr. Coburn, please come up, and she's going to talk to us about liver metastasis in the treatment, resection of liver mets in the treatment of NETs.
Thank you, Sharif. And thank you for Maureen and Jim for inviting me to speak about this very important topic. So Daryl and I decided that the best way to divide the surgical management would be to talk about resection of the primary and then resection of metastases. Metastatic disease is very important in carcinoid and neuroendocrine tumors because about a quarter to a third of patients present with metastatic disease. So when they have a primary, at the same time we find that they have spread to another site, such as bone or liver or lymph nodes. And Daryl just discussed lymph nodes, and I'm going to discuss liver because those are two of the things we can do something about as surgeons. Of patients who don't present with metastatic disease, another 50% at least, and it depends on which the site of primary is, will develop metastases over the course of their lifetime. And as we see patients living longer and longer with the disease, we find more and more metastatic disease. Surgical resection of hepatic metastases is important because we can get 5-year survival of 50 to 75% after resection. It's also a big challenge for us because about 80% of patients actually may not be surgical resections at the time of their presentation. So I want to discuss some of the options for therapy from our standpoint. First and foremost, we want to discuss liver resection, radiofrequency ablation, hepatic artery infusions, and then transplantation. So what we're thinking of as surgeons when we look at these cases is how do we improve survival and how do we improve symptoms. This is a lady who had carcinoid syndrome. She had significant flushing. This was before surgery. This is after surgery. Luckily, most of her disease was on the right side, although I don't know if you can see. There's another small lesion right over here on the left that was there before and after. But even though there's still some disease there after her surgery, her symptomatology has improved significantly. What do we do to assess our disease status? First and foremost, a CT scan of the chest, abdomen, and pelvis. We like to get an MRI of the liver because sometimes that shows us more disease than the CT scan does. Triotide scans and then hormone levels are also very helpful in decision making. There's a classification, as there's classification for everything, of liver metastases and neuroendocrine tumor. Type 1 is something like this, where you have one single metastasis of any size, and some of these can be quite large and quite frightening looking on the CT scan, but this is certainly what you would rather have, is one large one that's more easily removed than something like type 2, which would be multiple lesions bilobar or on both sides of the liver, or type 3, which is widely disseminated metastatic spread, and often there's no real normal-looking liver in these patients. Disease-free survival after treatment of liver metastases falls, as you would expect, by the burden of disease at presentation. So if you have type 1 disease, a low Ki-67 index, people do very well with a good extended disease-free survival. Type 2, you have more people who are recurring, so about 75% of people without disease. And then if you have type 3, the chance of having a disease-free survival or overall survival is significantly less, and that's what you would expect. And what are our expectations after liver resection? I think this is an important point that Daryl touched on. After we do the resections, patients will recur, and we know that happens. Within 7 to 10 years, most patients will have a recurrence. Whether it's in the lymph nodes or in the liver or somewhere else is what is the question. The other question we have is, are we doing the patients a benefit? In Ontario, there's a 2% mortality rate for single lobe resections. So that means of all the people who have a liver resection in Ontario, 2% will die from the surgery. If you do a more aggressive surgery, the mortality rate may be up to 6%. So we really have to balance that with what we're trying to achieve here. But overall, liver resection does appear to increase overall survival. If you look at multiple series within the literature, 5-year overall survival is somewhere between 60 and 70%, and it varies according to what you're resecting. And the interesting thing about carcinoid and neuroendocrine tumors that's very different from most of the other cancers that we treat is that we can debulk. So in most other cancers, if you can't get 100%, there's no point in going to the operating room. But in neuroendocrine, if you can get 90%, we're probably doing some benefit. And that's very good when you look at cases like this. This is a 41-year-old lady with carcinoid syndrome. She has 2 very large lesions. She's very symptomatic with a lot of diarrhea, flushing, tachycardia. She's 41 years old. So everyone look away, but this is in the operating room. These 2 larger lesions were resected. This is the final specimen. And afterwards, she had significant improvement in her symptomatology. Another thing that we can use in the OR or outside the operating room is radiofrequency ablation. Basically, you put a metal probe into the tumor, and you ablate the tumor using high-frequency alternating current. You fry it. It's very simple. Pros of this is that you can do this without going to the operating room. It can give you good symptom result and good tumor control. Unfortunately, it doesn't work too well if the lesions get to be more than about 3 centimeters. And if you have more than about 5 lesions in the liver, it's less effective. So how aggressive should we be? This is a series just recently published from France. This is one of the most aggressive groups of surgeons that we know of, and they frequently publish series like this. So they're resecting and or RFAing patients who have 15 or more lesions. They looked at 16 patients. The median number of lesions was 23 with a range of from 16 to 89. They did 15 plus or minus 9 resections and 12 plus or minus 8 RFAs. They posted no mortality. But this is a very small series. And then they compared it to their historical controls. So these survival curves look just the same as they did for a set of 47 patients with a median number of 7 liver metastases. So the message from this group is that if you can resect it, you should try to go for it. The other message that we've heard loud and clear is that debulking is a good idea. So cytoreduction, which is a removal or ablation of at least 90% of the total liver volume of tumor, does improve symptomatic relief, and it does improve survival. This is from the Promed study. I think we've seen this slide a few times today, but the important thing is in the patients who had a very large tumor burden did not really benefit from the long-acting octreotide, whereas those who had a smaller hepatic burden did. So we hope that if we can debulk patients to get them onto this graph, they'll do better on this red line as opposed to this red line. The other option we have that some centers are much better at doing than others, and I think your point's very well taken. We can't have a center of excellence for hepatic artery chemoembolization in every LHIN in every city in Ontario or across Canada. We do need to develop centers of excellence, and we do need to be able to cross-refer. But hepatic arterial infusion is a very important option for those patients who have too many lesions to resect. Now, neuroendocrine tumors are very special because they derive their blood flow from the hepatic artery. Most of the liver is supplied by the portal vein. So if you take away the hepatic artery, the liver itself does quite well. The tumors don't do well. The gallbladder also derives a blood supply from the hepatic artery, so it's quite important to remove that organ. If you just look at bland embolization, so just knocking off the hepatic artery, they studied 84 patients. 80% had an improvement in survival or symptoms. 80% had a reduction in biomarkers. Almost 50% had a radiologic response, which is a bit higher than most other studies, and there were very few side effects. Some other groups have thrown chemoembolization into the embolization of the hepatic artery. They've basically used every chemotherapy possible, which means that there's no gold standard and there's no clear front runner in this race. If you go to look for a randomized controlled trial of chemoembolization versus a bland embolization, there's no real good trials, but there's no proven survival benefit. There may be a better response from islet cell tumors. So things that are up and coming and things that are very expensive, so it might take them a while to come through, is radionucleotide therapy that you can also inject into the hepatic artery, things like yttrium 90 or lutetium 177. But I think someone else is going to discuss that at length. Liver transplant has been in the news a bit for pancreatic carcinoid recently. So what we do know is that liver transplant provides symptomatic relief in most patients. Early reports showed 5-year survival of around 36% or 47%, which is a little lower than what you would want to gain from a major operation such as a liver transplantation. More recent studies show 5-year survival of around 80%. This may be because we're better at picking patients. They're also better at transplanting. We also have better immunosuppressive drugs. So the more recent numbers may be more indicative of what results we're getting now. Nonetheless, this is a very infrequently used modality. It's for a very select set of patients, so a confirmed carcinoid histology. We certainly don't want to be transplanting in most other cancer situations. A primary tumor that's drained by the portal system, so if you have a carcinoid from the lungs, that gets to the liver in a more circuitous route. You want something that's directly drained by the portal vein, like a midgut tumor. Less than 50% hepatic replacement by tumor metastases, stable disease during the pre-transplantation period, and I think this is a very fuzzy recommendation, so there's no definite guidelines about how long or how stable, and obviously absence of extrahepatic disease. Some additional considerations: most transplant centers have an age cutoff. U of T is currently 65, I believe. Obviously, the primary has to be resected previously. Some centers have low Ki-67 proliferative index requirements. There's a very long wait times for transplants, especially in Ontario. And obviously, you have to be on lifetime immunosuppression. So for the right patient, this may be the right idea. So this is just a very simple algorithm for treatment of neuroendocrine tumors, but right down here we have how to deal with the hepatic metastases. And that can be liver surgery, ablative surgery, chemoembolization, or some combination thereof, and the one that's missing is transplantation. So in summary, many patients are going to present with or progress to metastatic disease, so we have to have an idea of how we're going to handle this during the disease course. Surgical resection of liver metastases likely benefits long-term survival and improves symptomatology. Debulking to less than 10% also likely benefits survival and symptomatology. RFA is something that we can use either as a standalone or as an adjunct to surgery. And hepatic artery embolization should be considered for patients who are not candidates for resection. Transplantation may have a role in highly select patients with non-resectable liver-only disease. Okay. And I think we're saving questions to the end.
Thank you very much, Natalie.